Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. I'm going to share with you today a nice case of pituitary neuroendocrine tumor, PitNET, what has been formerly known as pituitary adenoma of the Tip family, Corticotroph secreting a tumor. So this is a case of a 65-year-old female patient who is known to have a granulosa cell tumor and Cushing syndrome, and was found to have a pituitary mass that was excised through a transsphenoidal approach. And what I like about this case is that part of the normal pituitary gland was included, and so that we can contrast between the normal and the tumorous component. So this is the normal pituitary gland, where we have small nests of normal secreting pituitary cells of various morphology. And in contrast, this is the sheet of a tumor growing without formation of the typical nesting pattern that we encounter in the normal pituitary gland. And CAM 5.2 immunostain was positive in those nests in the normal, and was diffusely strongly positive in the cytoplasm of the tumor cells. Now, PIT1, which is a transcription factor that is very characteristic of the tumors, in particular somatotroph, lactotroph, and thyrotroph tumors, was negative in the tumor. It was not highlighting or showing positivity in the nuclei of any of the tumor cells. However, this is the normal pituitary gland, where we can see the normal distribution of these three cell types within the normal pituitary gland, and thus served as internal positive control in this case. Now, TPIT, which is usually the transcription factor that we see with corticotroph, this is positive in the tumor cells in the presence of internal negative control that would be consistent with the presentation of the patient. And this is the normal, again, highlighting the corticotroph cells that are present in the normal pituitary gland. And last is the SF1, which usually is positive in the gonadotroph, and this is the normal pituitary gland, showing only scattered gonadotroph cells, secreting cells, while the tumor was completely negative. Chi-67, I tend to do Chi-67 in cases of pituitary gland, although per WHO, this is not really usually recommended, but sometimes if I encounter an increased proliferative activity, more than 10%, I tend to report it and mention this clearly in the report. And this is the normal pituitary gland, hardly, if any, proliferatively active cells, while in the tumor, it's only occasional tumor cells positive, something like less than 2%, less than 1% eventually. And always remember to do reticulin stain, because sometimes if you don't have the privilege of having the immunohistochemistry, you need some way to confirm that this is a tumorous condition. Sometimes it's not easy. Remember that you always have the reticulin stain. This is the reticulin stain of the normal pituitary gland, where it tends really to highlight the nests of the tumor cells, and this is completely lost in the tumorous component. And on high power magnification, again highlighting the nests of the cells in the normal pituitary gland, while the tumor is completely negative. So to sum up, in this particular case, and in a patient with Cushing syndrome, the finding of a pituitary mass is consistent with pituitary neuroendocrine tumor, PitNET, which previously is known as pituitary adenoma. This is the new terminology that is recommended or now endorsed by the WHO. So no longer we use pituitary adenoma as a name for the tumor. And the immunoprofile was consistent with PIT family, which is corticotroph tumor. I hope you find this tip useful in your daily practice. Thank you.